Hello, my name is Christy Adams, and I'm the coordinator for the UC Davis Health Trauma Prevention Program. I'm also the chair for the American Trauma Society Committee for Injury Prevention. Today, I'm going to talk to you about hospital-based injury and violence prevention programs and what that looks like. I'm going to assume if you're watching this video, you're either an injury and violence prevention professional that works at a trauma center, or perhaps you're a public health professional at a local or county public health department who's interested in working with trauma centers on injury prevention in your area. So really, I wanted to start with a little bit of background on how trauma centers became involved in injury and violence prevention. And it really goes back to the Centers for Disease Control recognizing and acknowledging in the 80s that reducing the burden of injury really requires a primary prevention approach within a public health framework. Now, at the time, trauma centers were just being developed and really just focused on acute care of traumatically injured patients and really didn't put a lot of resources or effort into the prevention piece of it. So in recognition that primary prevention is essential in reducing the burden of injuries, the U.S. Department of Health and Human Services established that prevention should be a fundamental component of what's called an inclusive trauma system. Now, inclusive trauma care system is pretty much what it sounds like. You start with recognizing that the burden of injuries should be reduced through primary prevention. You also recognize that you can reduce the number of fatalities by providing appropriate trauma care. And then again, that you can reduce the long-term sequelae of injury by comprehensive rehabilitation. And that's pretty much the spectrum of an inclusive trauma care system. So moving forward to the American College of Surgeons, which the Committee on Trauma, which is the national organization that verifies trauma centers in the United States, they embraced the whole concept of injury prevention being part of the inclusive trauma care system and incorporated that into the document, which is called Optimal Care for the Trauma Patient. And within that, Chapter 18, it outlines that trauma centers, in order for them to be verified by the American College of Surgeons Committee on Trauma, must have an organized and comprehensive approach to injury prevention. So what does that mean? Well, the keys to an organized and effective approach, and again, drawing those words straight from the American College of Surgeons Committee on Trauma, Optimal Care of the Injured Patient Guide, which we refer to as the Orange Book currently. The organized approach really means, as a trauma center, you really want to have that institutionally integrated, developed across the disciplines and strategically planned approach to reducing the leading causes of injury that you have identified within not only your trauma center, but the community that your trauma center serves. And again, I mentioned multidisciplinary, but that's a key component for trauma centers when they want to have that organized and effective approach. It can't just be one injury prevention professional who's doing outreach or doing classes. It really needs to involve input from all internal stakeholders. So trauma program managers, CEOs, all your trauma surgeons, research department, really everybody needs to be on board and understand what it means to have a public health approach to reducing injuries beyond just caring for the trauma patients. So what does effective mean? Well, we know that effective reduction in injury and violence really comes from a public health informed approach. It needs to be community focused, and it really needs to be strategically implemented and evaluated. Again, looking at outcomes, ensuring that you know that your interventions are targeted for your community and you're measuring progress, and are you reaching your goals, and is it really having an impact on your community? So really, for developing an organized approach for a hospital-based injury and violence prevention program, it really does need to involve an institutional strategic plan. Now, I do recognize that oftentimes trauma centers will place the burden of injury prevention programs on a single individual who perhaps may be 0.5 FTE. Maybe they're also working as a PI nurse or a data abstractor or a data registrar, and wearing a lot of hats. We found across the country, this seems to be a consistent theme, that individuals within trauma centers who were tasked with injury and violence prevention at that trauma center, they tend to play multiple roles and have way more jobs than they're able to really embrace and accomplish. So our goal, and particularly in focusing on this webinar in particular, is to empower the hospital-based violence intervention professionals to understand that effective injury prevention within a trauma center needs to involve many, many people across the disciplines, across the departments, and integrate the community aspect of it. So we also understand that developing an organized approach for trauma centers is incorporating and leveraging mandates and existing policies and procedures. So I'm going to talk a little bit briefly about a community health needs assessment, which is something that's required of all hospitals who are nonprofits, and that's through the Affordable Care Act mandates. So finally, I will talk a little bit about what's called the standards and indicators for model level 1 and 2 trauma center injury and violence prevention programs. Now, caveat, it says level 1 and level 2, but these standards and indicators are absolutely applicable for any level trauma center or any hospital that's interested in developing a public health-based approach to injury and violence prevention. So moving forward, just starting with the basics of an effective approach to injury and violence prevention. We know that the public health approach, again, going back to the Centers for Disease Control, establishing this years ago, the public health approach is the absolute best way to reduce the burden of injury and violence in our communities. And so what does that look like? Well, you start with defining the problem. At trauma centers, within trauma centers, defining the problem is really going to be looking at your injuries, looking at your registry data, but also talking to your communities. What are the injuries that are affecting your communities the most? What are the injuries where you're seeing the most fatalities? Is it differ from age group to age group? The next step is identifying the risk factors. And again, that's going to differ from community to community. It may differ from age group to age group. And this is part of the comprehensive approach and really things that you need to think about before you implement specific injury prevention initiatives. Moving on to the next step, you select or develop the intervention. And again, when we talk about interventions, we're talking about very specific focused applications of the injury prevention strategies in the community. Step after that, implement the interventions and then evaluate the outcome. And I will say that evaluation is an ongoing process that really starts with defining the problem. And it's a step-by-step. And there are trainings available for actually multiple hours or all-day trainings available on this whole process. But I just wanted to highlight the flow of how this public health approach works, and particularly within the hospital setting, because it's very different from how hospitals care for individual patients who have been injured through trauma. So I do want to touch a little bit on that, because hospital-based injury and violence prevention programs are unique in that while we clearly have established that injury prevention is best focused through a public health framework, hospitals are acute care systems, right? They're caring for injured patients on the one-on-one. The intervention time frame is short-term. The outcome level is that single individual. They want to get those patients treated and out the door as fast as possible. The prevention focus in acute care trauma centers is really tertiary. How can we reduce the long-term impact of that injury that has already occurred? Within the aspect of research, the focus of trauma center research for injury and violence is clinical. How can we reduce those long-term sequelae from the injury that's already occurred. And then, of course, and this tends to be kind of the more relevant piece that's visible to all of us in this field in hospital-based injury and violence prevention, is the fiscal model. So hospitals are based on reimbursement and revenue for treating individual patients. And when you're working in injury and violence prevention, it's really challenging to have that conversation with your administration when the work that we do isn't based on reimbursement, revenue, or recharge of our hourly work. So shifting over to the public health model, which we've already talked about, but this is particularly what this looks like in the context of those acute care trauma systems. So imagine, if you will, you have an individual who is focused on injury and violence prevention using the public health model, but their job, their role, and their position is housed within an acute care trauma center. So everyone they work with, everyone that they're reporting to, all their administration has that mindset of acute care, treat the patient, treat the individual, get them out the door as fast as possible. Now, this person who's tasked with the injury and violence prevention work has to somehow relate the importance of using a public health approach and educate all those internal stakeholders before that comprehensive approach to injury and violence prevention can be implemented within a trauma center. So the primary purpose, as we know, for hospital-based injury and violence prevention is preventing the injuries in the first place. Again, and that just goes against the trauma center model of we need to treat the individuals here and now. The intervention focus for us as violence intervention professionals is that community and population. It's outside the hospital. Sometimes that's a hard conversation to have with the nurse manager when the work that you need to be doing is building relationships and building partnerships in the community with your stakeholders outside of the hospital. When your nurse manager perhaps wants you in the hospital, maybe doing bedside or feeling like your work is somehow associated with patient care, which should not be the case. Our intervention timeframe for violence and injury prevention, very different from the acute care model in the hospital. We're in it for the long haul. This is long-term commitment to building community partnerships, establishing those relationships, and that takes time. We're talking 3, 5, sometimes even 10 years of establishing those really lasting and genuine community partnerships and relationships, which is where the real work around injury prevention begins. Our outcome level is population and communities. We want to reduce injuries in the entire community, not just treat the single individual who's come in with the injury. And of course, for us, our prevention focus is primary and secondary. We want to prevent that injury from happening, prevent that incident, the crash, the fall, the whatever it is that causes the injury. We want to prevent that in the first place, which is primary. If we can't prevent the incident from happening, we want to reduce the impact of the injury, which is secondary prevention. The car seats reduce the injuries. Physical conditioning can sometimes reduce the impact of the injury during a fall, and so on and so forth. For us, a research model is community-based. We're not looking at how we can improve outcomes of a single individual necessarily. We really want to see how our programs impact the community overall. And then, of course, the challenging part for those that, if you've been in this work for any amount of time, have already recognized our fiscal model is a little different. The work that we do in injury and violence prevention within the hospital setting is not reimbursable, with the exception of a few small areas. We oftentimes are having to rely on grant money, soft funding, and things that don't necessarily adhere to the acute care trauma system model of reimbursement and generating revenue. So again, that can be a challenging conversation for us to have with our administration. But it's important that as an injury and violence prevention professional working in the hospital, that you understand these differences and how we really need to be advocates for the public health model. And we really need to be the ones who are educating our internal stakeholders about what that means and how that really is truly the only way to have a long-term and effective reduction in injury and violence in the communities around us. So I did want to talk briefly about conceptualizing a hospital injury and violence prevention program. And the reason I want to talk about this and kind of delineate the two different levels, if you will, is that oftentimes you'll hear people talk about their injury prevention program. And when they talk about their injury prevention program, they may be talking about something as specific as a car seat program or a senior fall prevention program. And it's important for a number of reasons, particularly around evaluation and strategic planning, that you're able to conceptually differentiate between what is the organizational structure within the hospital, the big P or the big program, and what is the sort of small p or the specific injury and violence prevention related work that are the programmatic interventions that take place in the community. And so this graph here, I think, gives a fairly decent representation of what this means and what that looks like. So really, when you're talking about an organized approach to injury prevention, in the blue box, you can see it encompasses the injury prevention professional working with the trauma program manager, the hospital administrator, you've got research and evaluation, your trauma surgeons are on board. And it really is that multidisciplinary approach of how, as we, as a trauma center, can focus all of our efforts or synergize efforts across the system to reducing injuries in the community. And below that, you'll see the 5 boxes that are titled leadership, resources, data, interventions, partnerships, which are really the core components of a comprehensive approach. And I'll talk about that briefly when I talk about the standards and indicators. So dropping down to the yellow triangles, just by way of illustration, these are the very specific programmatic injury-specific interventions that your program may focus on. Now, granted, for smaller hospitals or smaller programs, you may have one injury prevention professional. They may be full-time, they may be part-time, that's working sometimes in a silo, working without the interdisciplinary collaboration or support, and they have one program or intervention that they focus on. They may have a car seat program. So recognizing that oftentimes that's the limitation of hospital-based injury and violence prevention, it's still important to understand that the bigger picture and the long-term goal is to really have the blue box integrated approach, the big P, comprehensive approach to injury and violence prevention. And sometimes a program can have multiple interventions. Often you'll see if it's a pediatric and adult trauma center, they may have a child passenger safety program, and at the same time, they may have a senior fall prevention program. And again, that part comes into play when the American College of Surgeons, for those trauma centers that are verified, come out for their annual site survey. The first question the ACS will ask are, what are your leading causes of injury? And what are the 2 programs that you've developed to address those leading causes? Because that is pretty much word for word right from the Orange Book. So I had mentioned earlier about the community health needs assessment. And this is actually becoming an essential part of hospital-based violence and injury prevention programs who are wanting to develop that comprehensive approach. And quite frankly, when I'm teaching new injury prevention professionals about how to approach engaging internal stakeholders and getting that across the board support in their hospital, the first thing I will talk to them about is, if your hospital is a nonprofit, you need to look at your community health needs assessment. So the Affordable Care Act mandates that any hospital that is a nonprofit must have this community health needs assessment, which really takes a look at the community around them. What are the leading causes of health, health disparities, health issues, the leading causes of health concerns, and what are you as a hospital going to do about it? And so most hospitals, somewhere in their list of needs identified within their local community, should mention injury or violence. We know that injury is a leading cause of death for ages 1 through 44, and injury falls are the leading cause of fatality for older adults. So I would go out on a limb and say, if a hospital does not in some way recognize that injuries are impacting their community, whether it be older adults, or children in motor vehicle collisions, that perhaps in the next round of CHNA, Community Health Needs Assessment, they could reevaluate and look a little bit deeper at the data, because I guarantee every community in the United States is in some way impacted by injury and violence. So again, as an injury prevention professional, particularly as one who may be newer in the role, finding your community health needs assessment, talking with the people in your hospital who do that work, and identifying within that where injury and violence prevention falls in terms of priorities for your health system. And this is a fantastic way for you to leverage that internal mandate from the Affordable Care Act and get buy-in from your administration. So for example, what this may look like is if in your community health needs assessment, your administration has identified that in your community, falls and injury falls and fall fatalities among older adults is a huge concern, not just with the community, but the data are also showing that there's a lot of older adults coming into the trauma center with these types of injuries. If you have a senior fall prevention program or have been thinking about starting one, and your community health needs assessment staff or the administrators who are putting this document together aren't aware of your program, this is the place to connect. And you can go to them and say, hey, you know, I've taken a look at our CHNA. We as an institution have identified that falls is a leading concern and one of our objectives that we need to address. And my injury prevention initiative within my injury prevention program will help reduce those falls in the community. And I would like to contribute to our hospital's initiative to reduce those injuries. And so that's just one example of how you start building those internal connections and leveraging the existing mandates and finding your internal stakeholders to start building that approach. So just in summary about the Community Health Needs Assessment, also known as the CHNA, it identifies the strengths and resources available in a community to meet a particular need. It may also identify the gaps, which your program may be able to fill and assist your health system or hospital. The CHNA focuses on the capabilities of the communities, including its own citizens, agencies, organizations. So a good CHNA really does start where the people are. It talks to the local community members. What are the issues that they identify as problematic in addition to the data, and really focuses on what they feel are the primary health concerns, whether it be diabetes or child passenger safety. And then lastly, the CHNAs provide a framework for developing and identifying services and solutions and building supportive communities. So that ties right into the work that we do with injury and violence within the hospital setting of connecting with our communities to ensure that the work that we're doing meets their needs and is reducing that overall burden of injury. So I'm going to finish up this talk with an introduction and a brief overview of the standards and indicators for model level 1 and 2 trauma center injury and violence prevention programs. Long title, but very important document when it comes to developing your comprehensive approach for a hospital-based injury and violence prevention program. So prior to 2017, there was really no national standard for what a hospital-based injury and violence prevention program should look like. Yes, the American College of Surgeons had very brief directives within the Orange Book, the optimal care of the trauma injured patient on trauma centers must have an injury prevention program. Level 1 centers needed to have a full-time person and so on and so forth. But there really was no prescriptive guidance around how to develop that comprehensive approach using the public health framework. So the standards and indicators were developed by a grant from the Centers for Disease Control to Safe States and the National Association of City and County Health Officials. And it was a year-long strategic planning process that incorporated trauma centers, trauma health professionals, trauma organizations, and public health professionals across the United States. Now, the importance in that is this really is a consensus document, which means that every organization that has anything to do with trauma centers and also injury and violence prevention within the public health world were part of this document, and ultimately everyone came to the agreement on what it looks like and what it should look like for a hospital to have a public health founded injury and violence prevention program. So these standards and indicators, as I mentioned earlier, are not necessarily specific to level 1 and 2 trauma centers. They're absolutely applicable to level 3s and level 4s, or a hospital that isn't verified but would like to develop an injury and violence prevention program. One of the key elements of this document was the authors really wanted to strengthen that collaboration between the local public health department and trauma centers. And again, going back to the slide where I talked about the differences between an acute care trauma center and a public health approach, and really ensuring that there's an integration. And our role as injury and violence prevention professionals in the trauma center is to marry those two components between acute care and public health and ensure that there's understanding on both sides and that collaboration takes place. So the standards and indicators really come down to 5 core components. And if you remember the slide that I had pulled up that talked about the big P, or the systematic approach within a trauma center for the injury prevention program, there were those 5 little boxes under there that talked about leadership, resources, data, effective interventions, and partnerships. And so there actually Safe States has a fantastic webpage around the standards and indicators, all sorts of tools to get you familiar with not only the document itself, but how to use this document to assess your own injury and violence prevention program at your hospital, where your gaps are, where your strengths are. And it really just walks you through how you can use this document to build that comprehensive approach. And it's important to understand that these standards and indicators are not in any way intended to be a mandate. It's not a checkbox. It really is just a roadmap for you as an injury and violence prevention professional within the trauma center to follow in building that comprehensive approach. And so when you look at each one of these core components within that, the document will list indicators that will tell you if your program is reaching that level where it really needs to, in terms of leadership. Are you having regular meetings with your leadership? Does the leadership understand what a public health approach is? Do you have support from your leadership? All the way to resources. An example of some of the standards within the resource component is, do you have sufficient funding? Do you have sufficient staff? And honestly, we recognize that so many prevention programs across the country based at hospitals don't have that. Again, going back to, because our work is not reimbursable, hospitals do not always provide support. And again, this document really is a way to get buy-in from your institution, saying, hey, look, nationally, there's standards for what a hospital program should look like. Here's the metrics that we should really strive for, and here's how we can achieve that. In terms of data, everybody needs data to determine their leading causes of injury, but there's so much more we need to be doing with it. We need to be evaluating the implementations of our programs. We need to be looking at our long-term outcomes, process intervention. Do you have the resources internally? Do you have a data analyst? Do you have an epidemiologist? Are you partnering with your local public health department around the community level data and the integration again of the outreach and initiatives between trauma centers and public health departments? Effective interventions. Are you using evidence-based programs in your trauma prevention program? Are you using licensed programs? Are you following the fidelity to the program, and so on and so forth? And then finally, and for me personally, I feel like this is one of the most important components of a hospital-based injury and violence prevention program is, are your partnerships strong? Are they enduring? Are they genuine? And are they really contributing to the work that you're doing? And partnerships range from anything with the local MOU to a nonprofit to your local state public health departments. It could be schools, churches, whatever organization you have in your community that is vested in reducing the injury and violence in their population. So again, encouraging those of you that are working in the hospital setting, particularly if you're a new injury prevention professional, please go to the Safe States website and take a look at the standards and indicators. Up front, know that when you open the document, there is a lot of content. It does take some time to work your way through it. But again, my suggestion is take it one bit at a time. Sit down, have a conversation with your trauma program manager or your administrator, and really get an idea of where your program sits within the overall sort of comprehensive approach to injury and violence prevention. And more importantly, identifying within these 5 core components, the areas that really you could work on strengthening and areas for improvement to build that overall approach. And again, reducing injuries and violence in your community. So that concludes this session, and I thank you for your time.